to the Home of Medicine podcast with me, Dr. Amie Burbridge. Today I am joined by my ever faithful co-host.
Hi, I'm Dr. Ben Lovell and thank you for having me back again.
Absolutely, always a pleasure. So Ben, we're going to go straight in with today's case.
I'm ready.
So this is a lady I saw in March 2021 and she stands out probably because she's one of the last patients that I saw just before I was about to go on maternity leave. So she stands out probably because of that, but also because her presenting complaint and what she ended up having was different to what I originally thought. So she was seen in the emergency department on the 18th of March last year with abdominal pain, and she was discharged with no acute medical problem. And I saw her a week later. She's a 23-year-old female, normally fit and well, with no significant past medical history of note. She has a past psychiatric history of depression, for which she has had one hospital admission with a few years previously. And she's had a few episodes of deliberate self-harm as well in the past. She presented with a 1-week history of chest pain. On further questioning, she said the chest pain was worse on the left-hand side, and it was particularly bad on inspiration. There was no change in the pain on movement, so it didn't change on position. And she didn't really have any associated symptoms with this chest pain. She didn't have a cough. She wasn't bringing any hemoptysis up, any phlegm or anything like that. She did say that she felt a little bit short of breath, though. And she said that in particularly on climbing upstairs, she felt short of breath. She was normally fit, went to the gym, did exercise, but over the last few months had been feeling short of breath. But she'd only had the pain for 1 week. So that's the information so far. So what I want really, I guess, is your initial thoughts from that very brief history that I've given you.
Well, that patient is almost a textbook, a template of the many dozens of presentations I get through ambulatory care every week. So already I'm sort of reaching for my common things that I see or common things that I want to rule out. And how old did you say she was? 22?
23.
23 with what sounds like pleuritic chest pain for a couple of days.
She'd had the pleuritic chest pain for a week.
For 1 week on a background of worsening breathlessness on exertion for a month, I think you said. Okay, so pleuritic chest pain in a young woman. I'm going to think, number one, could this be a PE? And how do I go about assessing for that? Could she have popped a little pneumothorax? How do I go about assessing for that? Less common things, I'd be wondering about infection with a bit of pleuritic reaction, but people with infection, chest infections, would be complaining of lots of other things, such as a cough and sputum and fever, and it wouldn't be rumbling on for many months. So there'd be my two big ones that automatically pop into my head. I mean, you said this was March 21, and I think, this is mid-pandemic, and I can't remember if we were vaccinating at that point yet, because
we were. They started in December 2020. And I know that because the first vaccination was where I work.
Oh yeah, you're right, because my first vaccination was on Christmas Eve. Yes. So happy Christmas to me. So I asked that because I know that vaccine reactions are rare, but we saw them because they presented to healthcare. So they weren't so rare in acute medicine. And in young people who'd had the vaccine, who came in with symptoms that could be a PE, that's when we also start thinking about, could this be connected? It was actually my hospital at UCLH where they first described vaccine-induced thrombocytopenic thrombosis, the VITT syndrome. And we became very, very sensitized to that and looking for venous thromboembolism, anyone who came with symptoms that could be consistent with a DVT, a PE, or a cerebral venous sinus thrombosis. She definitely gets a set of bloods, and she, looking at her FBC, she definitely gets herself a chest X-ray and an ECG. And I guess of course, I'm going to examine her and try and elucidate whether or not I think this could be a PE or not. If it is, she goes down the Wells Score Road, looking at PEs and such like. But if that doesn't fit at all, then I won't go down that road.
Okay. Absolutely. Is there anything else that you'd like to know from her?
I guess I'd be looking for risk factors for thrombosis. So, of course, the vaccine, as we've mentioned, but is she someone who has had clots before, has a family history of clots, or takes any medication that makes her like to have clots? You said she was fit and well, didn't you?
I did. She doesn't have any family history. There's no family history of blood clots. And she's on the Depo-Provera injection for contraception, which is a progesterone-only contraception.
So progesterone-only contraception is pretty blameless, isn't it, as terms of contraceptives go as being prothrombotic. But of course, she could have an unprovoked PE. So I'm not willing at this point to say no way it could be a PE. You said you could. Did you say you couldn't reproduce the pain? And did you get your fingers into the intercostal spaces to see if it was reproducible or palpable?
Yeah, so that is one of my favourite things, and I shouldn't do it because, when you think about it, I press on there and I'm like, oh, that hurts. Do you know what, I'm doing that to myself at the moment, and I went to boot camp a few nights ago and it really hurts still. So, and it's, what is the diagnostic association or the sensitivity and the specificity of a tender chest wall and costochondritis? I'd be really interested to know that. I mean, it's something I need to look at, actually.
That's a great
so she, as I said, she denied cough and syncope. She had no swollen ankles, no palpitations, no syncopes. I've already said that. And examination-wise was entirely normal. Okay. Nothing at all. Chest was clear, heart sounds were normal. I did palpate and there was no tenderness in the chest wall or around the area. And what I always do when somebody has chest pain is I get them to put a finger on the exact spot where the pain is, and I will press it, but I will also auscultate in that area, because sometimes they might have a localized pleurisy and you can sometimes hear that sort of Velcro rub. And also the same with pericarditis. I will often listen in the exact point where they have that pain. Again, I don't think there's any sensitivity or specificity associated with this, but it's something that I like to do. She had no pedal edema. As I say, everything in the examination was entirely normal. She looked incredibly fit and well. And I went down that pathway of there's absolutely nothing wrong with her. She looks fit and well. She's 23. Yes, she's had pleuritic chest pain, but actually her observations are completely normal. She's not tachycardic. She's not hypoxic, saturations are 98% on room air. Her blood pressure is completely normal at 120/77. She's apyrexial and her respiratory rate's normal. So, I thought, actually, do I even need to do any investigations at all?
Interesting. It's very, very hard to stop that road once you've gone on the road. This is why I am in awe of GPs who are doing this all stuff in their own GP clinics. And sending someone in for investigation is not a small decision if you're a GP. It involves sending the patient to your local hospital to see me, and making that decision must be very tricky. For me, it's almost harder to stop doing investigations like blood and ECGs because I'm often handed them as I'm handed the patient, because they're so efficient. Someone's done them as she's stepped foot in the front door of the hospital, along with her observation. So I often get tests I didn't even ask for. But if someone is referred to me by a colleague, say a GP in the community, or by an ED physician with, hello, I think this patient has pleuritic chest pain and needs workup for PE, for example, or cardiac chest pain, it is very unusual that I examine the patient, assess the patient, I go, stop. No, they don't, after all. I prefer my findings to your findings, and I'm going to stop now. I've done it maybe maybe I do it once a year, but it's actually very rare that I do, because I'm very much influenced by those who've gone before me, whom I respect, and have made a recommendation that they deserve investigations. So it takes a very, very certain position to actually go against that and say, I decide not. I do it, but it's not common. I don't know about you.
Again, it's not something I do frequently. It's something that I probably did a little bit more during the COVID, when patients weren't seen face-to-face as much in the community, because actually if they hadn't been seen face-to-face, then I then saw them and then took a history and examined them, I may come up with something different that was sort of the history that was taken over the phone. So I think it was a lot more common then. Sure. However, I agree, you know, if a clinician in the community has seen them, examined them, took a history, examined the patient and felt that they needed investigations, it's very difficult to backtrack on that. And also, the patient has an expectation
Mm,
that they are coming in for tests, you know, and most patients are, you know, who come into our department before they've even seen me actually have had an ECG,
yeah,
and usually had baseline bloods done as well, actually.
yeah,
Whether that's right or wrong,
yeah.
I don't know. And we're having that eternal debate really about, you know, who decides what blood tests they have when they come in the front door, because they seem to get a bit of everything, you know. In an NHS which has finite resources, should we be doing all of these multiple tests on patients before they've even seen anybody? Not
Yes,
sure.
because surely a test should be a decision based on an assessment, on a history examination.
Mhm,
Then you choose your tests. And we do it completely the other way around. We do the test,
mhm.
then we examine and take history of the patient, and we try and make the tests tessellate with what we find, which can sometimes
Absolutely.
be tricky.
Yeah. And the problem is if you've got the investigations in front of you before you've seen the patient, do you then take a different history to the one that you may have done when you hadn't got the blood tests?
Of
So
course.
are you now searching for a diagnosis that fits the investigations that you've got in front of you?
Of course,
Poss-
absolutely. Even if I
yeah.
didn't want to, how could I not? If I'm
Yeah.
handed before I see a patient, oh, by the way, here's their troponin, which is ever so slightly above normal, I'm going to go in and take a troponin history, you know, whatever that is.
Mhm,
You know, I'm going to be trying to explain the troponin. Whereas I
mhm,
wouldn't necessarily have done that if I'd gone in blank. And I do think we often do preload our assessments with too much data before we go in. And I think that's a side effect of the amazing electronic healthcare systems, which a lot of us work in now. For example, at my hospital, you can go on, before you go to the patient, you can go onto our electronic healthcare system, Epic, and you can pull up anything you want to know about that patient since the first time they ever came in contact with a doctor.
wow.
And that's why I find it very interesting when doctors, when trainees are going to clerk a patient, and then 30, 40 minutes later, they're still at the computer digging through, you know, old clinic letters and old blood results, and they haven't seen the patient yet, which is a new since I was at that stage,
Mhm,
because I'm so blooming old. We didn't have anything like that. You had to go in completely blind, and it has so many benefits because you can get accurate histories and medications and all blood results. But I think you get a very distorted signal to noise ratio in that you get flooded with so much information. It can take a long time to pick out which is
mhm.
pertinent to this attendance today, which is the
Yes.
art of acute medicine, I think. So, yes, if someone hands me a lot of data pre-patient, but pre-contact, that is absolutely going to frame what I then do at the patient's bedside, whether I
Mhm,
intended to do so or not, for
mhm.
good and for bad.
And do you think that's a good thing or a bad thing?
I bet there's both. I bet
Mm,
I know I've walked away from patients and I thought I never would have picked this up if I hadn't known about this previous thing that I got
mhm,
from their records. Wow, that what a lifesaver that I knew that. It meant I didn't miss something.
mhm.
But I've also come away from patients expecting it to be one thing, and it's not.
Mhm,
Oh, I thought you were going to have a flare up of your SLE, and I was prepared to bung you full of all these drugs. You've got a cold, that sort of thing. And I've gone in
mhm,
prep for one reality, and actually it's another one.
mhm.
Maybe I've not even know. I still carry in this preconceived bias that it's the thing I thought it was going to be, because it's so hard to train to change your mind lines,
Mhm.
the track of thought that you're following.
Yeah, I completely agree. And it also depends on how busy I am at work.
Mm,
So if I'm incredibly busy, I will often look at the data before I go and see the patient. If
mm,
I'm less busy, I would often pick the notes up, not look at anything apart from the observations and go in blind.
yeah.
So I do it both ways, and I don't know which one I prefer. I don't know which one's best for the patients, to be honest. I don't know, and I think that's something that we're continuing to evolve because where I work, we still are based on paper. So
Mhm.
we don't have access to a lot of past medical history. So in your situation, it sounds like there's a lot more data there to go through.
Yeah.
So I think I'm sort of somewhere in the middle. So I'm going to carry on with our patient anyway. And I reviewed her, I examined her, didn't find anything. And she had some routine bloods done. And I said to I was actually finishing work and I handed her over and I said, "Do you know what? These are going to be completely normal. You can, check the bloods, make sure they're okay and send her home. I don't think there's anything wrong." So I had a long chat to the patient and she was really anxious about what was going on and why she was in hospital. And I reassured her and said, honestly, I'm sure there's absolutely nothing wrong. Everything's absolutely fine. And she'd had a chest X-ray, and I reviewed the chest X-ray. And where she had the pain on her chest, on the chest X-ray, there was some subtle consolidation. So I was like, you've actually got a chest infection, actually. I've seen it on the chest X-ray. You've got a little bit of inflammation within the lungs. I know you haven't had a fever or a cough, but sometimes that can come in a couple of days' time. She had a CRP done, which was 16, so that was a little bit elevated. Her white cell count, however, and neutrophils were completely normal. Kidneys, normal. Liver, normal. Everything normal. So I was like, I think you've got a bit of a chest infection. We could think about giving you some antibiotics because obviously we've got changes on the chest X-ray. However, then the doctor, the trainee doctor who I'd handed over to, said, have you seen this? And her D-dimer was 1.57.
And what's your normal?
So our upper limit of normal is 0.5.
Okay.
And hers was 1.57. So it was over 3 times the upper limit of normal. So I was like, oh gosh, what do I do with this D-dimer, which is the eternal debate I have. Pleuritic chest pain, shortness of breath, raised D-dimer. This is a pulmonary embolism until proven otherwise. So was I then still confident to send her home, which is what I wanted to do? They had this unexpected D-dimer. I then had to go down the path of PE, or did I? Did I have to go and investigate even further? Because, it didn't sound like a PE. I'd got changes on the chest X-ray that was consistent with an infection. Or could this be infarcted tissue? I wasn't sure.
You sound like a radiologist, because whenever I ring up and say, they say, but you've got your diagnosis, what are you looking for more stuff for? I guess my answer is always the patient is allowed to have 2 problems. And it is not without the realms of possibility to have a touch of pneumonia and a superadded PE, because having pneumonia is a prothrombotic state. And was the consolidation very peripheral?
Yes.
Then that can be an infarct, can't it?
Yes.
So it could be that she's had a little peripheral infarct, which is caused by consolidation. And then, do you ever look for Westermarck sign?
Do you know, I love a bit of Westermarck sign. So that's an area of oligemia, isn't it, in the lungs?
Yes.
And I think every new block of trainees that come in, I'm like, tell me about Westermarck sign. Yeah. They all know the answer now. I think they're prepped. Dr. Burbridge will ask you about Westermarck sign.
If you could convince yourself the consolidation was peripheral, it was triangular, wedge-shaped. There was
absolutely
a dark oligemic patch there above it. And then as raised CRP, then I find it very difficult to resist that. CTPA, I have to say.
Mm-hmm. Yeah, absolutely. So I went back and had a chat to her, and I said, we've done some tests. I've done a chest X-ray. It looks like infection, but also I'm a bit concerned that actually sometimes this could be a blood clot in the lungs, and I need to do some further investigations. And again, she was incredibly upset, and I reassured her. And I think I have a problem in over reassurance. So I will often say, I'm really not worried about this. I think everything's going to be fine. If there is a blood clot, we can treat it. But I don't think there is. And this is why I don't think there is, but it still is a possibility. So I love a bit of over reassurance, which I know isn't probably I don't know the right thing to do in all situations, but I felt that actually this is what she needed. So I went ahead in our patient, and we did a CTPA, and the result came back that night with a very surprising diagnosis and completely left field. And I was really shocked by the diagnosis, because I'd spent ages and ages and ages reassuring her that everything was going to be completely fine. And the CTPA was reported with no peripheral pulmonary embolism. However, there was a large thrombus in the heart, large thrombus in the atrium, in the right atrium. And I was like, whoa, that was unexpected. What do I even do with the right atrial thrombus? It's not something that we see often. And I was like, okay, right, what do I do now? So it just threw me.
I'm very interested in her vaccine status now, because that is a super rare condition in someone who's not got no reason to have a thrombosis. What was the consolidation then? She also had infection, did she?
She had an infection as well. So like you said, Here comes dictum. Patients can have as many diseases as they damn well please. And she did have two separate entities. So she did have a bit of an infection, but she also had this right atrial thrombus, which was thought to be the cause of the elevated D dimer, which would fit and make sense.
I'd wonder if she had that right atrial thrombus. I suppose they were absolutely certain that it hadn't showered off any emboli at all down to the PEs, down to subsegmentals, and caused a tiny bit of pulmonary ischemia and infection. It seems like a hell of a coincidence, doesn't it, to have those two things which you could theoretically connect together. I suppose if this has happened to me and it was the night, I'd just give a full dose low molecular weight heparin dose, book an echo and a cardiology view for the morning, and I've got a feeling that intracardiac thrombus, you're looking at warfarin, good old-fashioned warfarin, rather than NOACs, which I don't believe are validated for that yet, which is not very good for her because that throws up lots of other lifestyle and all that sort of stuff. But where would you go looking for a cause? Because it'd be difficult just to say at that point, oh, whoops, you've got a cardiac thrombus, here's your blood thinners and have a nice life.
Bye. Exactly. Yeah.
It's like, what happened in your right atrium? What's happened? So I wonder if she would then go down the road of having an echo and a cardiac MRI. Has she got some weird anatomy in her right atrium which has caused blood flow?
That's really interesting that you said that. So she was diagnosed with right atrial thrombus and, as you rightly suggested, started on warfarin. Absolutely. And she was reviewed by the cardiologists who diagnosed right atrial thrombus, continued with warfarin for a cardiac MRI to identify what actually is going on in the heart. And on the MRI, it was reported as a large mobile mass in the right atrium, consisting with a thrombus on the eustachian valve. So we have two things in our body named after eustachian, the eustachian tube, and obviously the eustachian valve. I hadn't heard of that. So
I only know it because I did my BSc echocardiography, and I hadn't heard of it until that moment either. But it's a physiological finding, isn't it? So it shouldn't be causing obstruction or anything like that. I never heard of it causing a thrombus before.
Yeah, absolutely. And so, I mean, in her, she did have this thrombus, but she didn't have any signs of cardiac failure associated with the thrombus, which was good for her. So she was diagnosed with right atrial thrombus, started on warfarin, and then followed up quite frequently by the cardiologists. Now, at 4 months, I kept following her up because I was really interested about this case. So at 4 months, she was reviewed again by the cardiologists and had another cardiac MRI because she was still incredibly symptomatic. And actually what had happened is she'd started to become more and more short of breath. She'd started to become very tired, very fatigued. She'd lost a little bit of weight and just wasn't right. And she wasn't improving as was expected by the cardiologists. And in fact, she was deteriorating. So she came into hospital again as an emergency admission. And she came back into the acute department with shortness of breath, weight loss, fatigue, night sweats, just not feeling right, looking particularly unwell. An examination again didn't really reveal any signs or symptoms. There was no heart failure noted. There was no evidence of embolic phenomenon in the rest of the body. So she didn't have any now-followed infarcts, any splinter hemorrhages that would suggest septic embolization or embolic disease from the thrombus. She had a chest X-ray which didn't show anything apart from resolution of that left pleural change that we noted earlier. And yeah, it was challenging. So again, we really didn't know what to do. So was this symptoms? Were they new symptoms? Was something else going on? What would you do? Because she's represented to the acute medical department.
Is she hypoxic? Again,
no, never hypoxic.
Just very breathless.
Incredibly breathless.
And did you have a repeat CTPA? She wasn't embolizing into PEs, was she? Did you say?
So she didn't have a repeat CTPA at that point. And rightly or wrongly, I don't know whether you agree with this, but a D dimer was done. And the D dimer was negative.
I wouldn't know how to I do not know how to interpret D dimers in the context of someone who's anticoagulated on warfarin with an existing clot. I would throw it in the bin and pretend I never saw it. Yeah.
I completely agree, because again, D dimer is a fibrin degradation product. will warfarin affect that? You know, which part of the pathway does warfarin affect? Any part of the coagulation cascade? We know it affects clotting factors 2, 7, 9, and 10. You know, how accurate is that D-dimer going to be? So I agree with you. I don't think a negative D-dimer would rule anything out, and it certainly wouldn't mean that I wouldn't do a CTPA to look for further.
Yeah, yeah. Did her ECG change over the course of this time? She didn't develop any sort of new right heart strain or any funny patterns or bundle branch blocks or anything?
Well, that's interesting you should say that. So actually, she didn't notice there were some changes on her ECG, and she wasn't tachycardic, but we knew that it looked like the atrium. So when you've got atrial hypertrophy on an ECG, you can see changes in the P wave. Okay, so you can have P pulmonale for right atrial hypertrophy and P mitrale, and there was some evidence of right atrial hypertrophy on the ECG, which was interesting. So we got the cardiologist and we're like, we don't know what we're doing. This is far outside of our, our specialty. So she had a repeat MRI heart, and this is where it gets interesting again. The MRI of the cardiac MRI was done, and it was reported as a right atrial myxoma, no evidence of thrombus.
Was it obstructing? Was it obstructing the tricuspid valve or anything like that?
Not majorly. I mean, there was some obstruction there because she was starting to get short of breath. But what was really interesting, speaking to the cardiologist and looking at the report, is that it was likely that this patient had never had a thrombus.
I mean, this is tough. This is really a disaster for that patient and for people who have made clinical decisions for that patient, because she has been exposed to, I don't know, a long time of a major medication with side effects. She has psychologically absorbed one diagnosis and then will have to be told it was incorrect, and it's the second one. So that would probably be a very interesting internal investigation at your institution, which I do not pity anyone involved with. I mean, I wonder if, looking back at the first MRI, now with their knowledge, was a second report issued, or did they say, no, this really looked like a clot?
So it's really interesting to read the reports, because it is still reflected that it does look like a thrombus, and the reasoning behind that diagnosis is given very, very clearly. So I guess I find this case interesting for many, many reasons. Firstly, she came in with that typical presentation of chest pain in a young female. And again, my cognitive biases were there. It's going to be nothing because she's young and fit. And actually, she had something quite serious. I wasn't going to do a D-dimer, and it was done. I still think about this case now. If I'd seen her without any bloods being done, I wouldn't have done a D-dimer. She wouldn't have had a CTPA, and this wouldn't have been picked up.
And you can imagine presenting to a GP surgery with similar, and they making an assessment and saying, I don't think you need to go into hospital for investigation because there's no red flags here. And these patients exist. They exist, and they do. We talk about biases, and one interesting bias in healthcare is recent case bias or disaster bias. Whereas when we see one zebra, one abnormality, we look for it everywhere else. I remember when I was a trainee, I think I was an SHO, and I had a registrar who insisted that you did a breast examination on everyone who came in with an infection. And I said, why are we examining all these poor women's breasts? And he said, and it turned out because he'd once missed a really bad abscess in someone's breast, and he was terrified of missing another one. And that is previous case bias. That's disaster bias, and it does mean that clinicians, when we're affected by it, over investigate for a long time after, weeks and months after, because we think, God, remember that one patient we almost missed. So and then every person who comes in with a bit of chest pain ends up with tests, sometimes invasive tests or tests involving radiation that have side effects, because we want to be thorough and we don't want to miss the atrial myxoma, which is as rare as rocking horse manure, but it stays with us and it leaves a little scar. It affects our thinking going forward.
Absolutely, and that's what I took away from this case. I don't think I've ever seen an atrial myxoma, in my career. I think this was probably the first patient who I saw from day one of the, often I'll see patients who've been diagnosed previously and they've come in they may have had a right atrial myxoma, an atrial myxoma, or it's already been diagnosed. But I've never seen somebody from first presentation who's been diagnosed with atrial thrombus or an atrial myxoma. So that was quite a surprise to me. And also, she was incredibly well. So I assume that somebody who had a thrombus or a myxoma in the heart would be more unwell, would be more short of breath, more fatigued, but maybe have signs of heart failure, maybe have a raised JVP, swollen. None of that. And that really shocked me at how well she was. And I think just because patients look well and feel well, it doesn't mean they are well. And I know that's sort of crazy thing to say, because we see so many patients, and we have to have a filter at work, don't we, where we go, are you well or unwell? You're well, okay, because it's so busy and we see so many patients.
I think especially in acute medicine, and I assume also in emergency medicine, we often when a doctor is presenting a case to me, and they're going through a very fantastically detailed and thorough history, and sometimes I'll listen and I go, but are they sick? Are they ill?
Yes.
Do they look ill or not? Because I can't quite contextualize all this information. I'll go and see them in a minute. And what I'm asking there is, I'm asking them to use gut instinct, I think, a little bit.
Yeah.
When we wrote our textbook, we call it the endobedogram, because you're standing at the end of the bed and sort of taking a picture and making a judgment call. And it's not that I would base my entire assessment on does the patient look well or look ill, but it is useful when you're adducing all the information and you're trying to make decisions, particularly decisions about do you need to admit them or not. Because now in the world of ambulatory medicine, we can treat a lot of people on an outpatient basis, even coming into hospital every day, but they can sleep in their own bed at home overnight. And sometimes making that decision, which I know less experienced doctors find very tricky, who can go home. A lot of it comes from, but do they look ill? Do they look well? If they look well, look, it's 5 p.m, send them home, bring them back to tomorrow, and we'll do it all tomorrow. And that feeds into all of my discharge planning, decision making, and whether ambulate or admit.
Yeah, absolutely. I completely agree. It's we get in the numbers of patients that we see now in acute medicine compared to when I started my consultant job a few years ago. It's incredible. The numbers coming through the door are huge. And in any one day, you can see 40, 50 patients, and it is incredibly challenging. Can you actually accurately see, investigate, diagnose and manage that many patients properly? I don't know. The pressure's intense. It's very different to what it used to be.
And the decision fatigue that goes with it, it's a very
absolutely
symptom. At weekends, we do a full round of our ward, and it's 56 patients, and
we
have to get to the 30th patient, and someone's presenting it to me, and I feel like saying, I'm sorry, I cannot absorb any more stories. I can't any more narratives today. He's starting, okay, so 64-year-old patient presents with, it's like, I can't go back to the beginning with a new patient. I come home and my husband will say, what do you want for dinner? I'm saying, I can't decide.
I don't know.
I know you'll have to just decide for me. I'm out. I can't even just, don't ask me any big decisions about what color curtains I want for the bedroom. Forget about it. I'm done.
I know. And it's so I'm working this weekend. I'm on Sunday, and I know I've got to do that big ward round. And I'm already thinking, because obviously at the weekends you have a lot fewer staff, and I'm thinking, how am I going to see all these patients? Because you're right, after a certain time of hearing so many stories, they all sort of blur into one. And it's, how can we make it better for us and the patients then when we see this many patients at weekends? Do you have any tips, as to what I can do to make my weekend bearable?
I think you've got to take little break. I think sometimes we said, come on, the only way out is through. Let's just get through it. And the one thing I would say is, remember, it's not just you. You are leading a team of other people. Maybe there's, trainee doctors there with you who are way too polite to say, Dr. Beveridge, I'm falling over. I need to have a drink or something to eat. Or you've given me 9,000 jobs to do, and we're only at patient 29. Please give me 20 minutes to get started on this stuff before we do the next 30 patients. If you feel that you're in the zone and you're on fire, or you just want to get it done, just get this done. I think you have to force yourself and your team to say, we're going to stop, meet you back in 10, toilet breaks, snack breaks, coffee breaks, just to give yourself a decompression time and go somewhere quiet. Because saying, okay, let's just sit down here in the middle of the ward, bells ringing, alarms going, you're not going, you need to go somewhere silent.
Yeah, it's a very good idea.
I say to a lot to the trainee doctors when they're taking their break, and they like to take their breaks in the office so they can chat. I'm like, why don't you go to the staff room and do it around there? Because it's just quieter, and you won't get people coming in saying, hello, I know you're on your break, but the patient in bed 4, just getting away from the sensory input. I think it needs to be done. That's the only way I can think.
Small breaks, small and often. Yeah. I often, I'll keep going to the toilet even if I don't need them. I'm just going to the toilet, and they must think I've got a really weak bladder because I can go walk to the end of the ward and then shut the door, and then nobody's going to knock on the door, are they, and say, come on, Amy. Well, they might do, but it's quite nice. Yeah. So and I think you're right, actually. It's about taking those 5 to 10 minute breaks every 90 minutes, I guess, actually.
But I think also demonstrate, I think that's leadership. I think it's a very sad image, isn't it? The doctor sitting in a locked toilet, which is the only place that could get any peace and quiet for 5-11 seconds. And I think we need to demonstrate leadership. Okay, everyone, down tools. We're all going to stop now. And look, I'm stopping. You're stopping. We're all going to stop. Just to show them that it's that we do it. We do take breaks. We have a culture of taking breaks when when they're allocated and finishing on time. It's a hard hill to climb to sort of break that old-fashioned culture of you just keep going until you drop. But I think we consultants have a responsibility to try and chip away at that.
And we've obviously had a changeover recently of doctors because it's August. And I was on Monday and I kept saying to all of them, have you had your break? Have you had your break? Have you had your break? Yes, I've had my break. Yes, I've had my break. And one of them said, have you had your break? I was like, no. And they're like, well, why don't you go and have one? I was like, oh yeah, I'm telling everyone to do it. And it's really interesting, actually. I think I need to be a more positive role model. Yeah. So not only telling them to have a break, but also do that myself.
I'm going for my break now. You are welcome.
I'm going now. Yes. Yeah, absolutely. So I think then to round up, really, I guess, this case, there was a few things. I guess it was less about the clinical sides of this case, but it was all about, that typical, anchoring bias of the patient presenting to me with chest pain, pruritic in nature, looked well. She was fine. She was young. I wasn't worried. But actually, I missed it. I mean, to be honest, I wouldn't expect anyone to diagnose a right atrial myxoma in acute medicine just from history. That would be really impressive. But, it's about sometimes thinking, actually, patients can look well, but still be incredibly unwell. And I guess what I should have done a little bit more with her is she was really upset and just kept saying to me, it just doesn't feel right. So, I should have listened to that more, because the patient is always right, aren't they? Her gut instinct that something wasn't quite right. So, yeah.
That's a very interesting.
Any thoughts?
Very interesting case, Amy. As you say, we're not expecting people to clock a myxoma, in a ambulatory care or in the AMU. I guess it's just a really good sort of thought exercise. And when can you feel comfortable in saying stop and discharge? Or when do you continue? And sometimes the patient can guide you on that.
Yes, and I think what we need to do more, and there's another case actually I think would be a good for discussion on this, but just briefly, it was a gentleman who was said to be end of life, needed a procedure, and 2 specialties were debating about whether he needed this procedure, whether he was well enough, etc. Nobody asked him, the patient. And when the patient was asked about the procedure, he said, I want to have this procedure. I want it done. And that was 4 days of discussions between the 2 specialties before anybody had sat down with him and said, what do you want to do? And he had the procedure, and it made a massive improvement to his quality of life. So
yeah, I mean, I could talk for hours about end of life and palliative care within the world of internal medicine and what we do.
Oh, absolutely. Yes, yeah. But it was really interesting that, we do all forget it. I know I do, is actually ask the patient, what do they want? What do they think's going on? What you taught way back at medical school, what are their ideas, their concerns, expectations? Go back to that, what do you think could be going on? Because actually it can be quite telling sometimes. And what do you want us to do?
Yeah.
Definitely. Thank you so much, Ben. I hope that you listeners out there found it interesting. So thank you so much to everybody out there for listening. If you have any questions at all, please tweet me at Amie Burbridge. And looking forward to you all tuning again soon. Thanks for listening. Goodbye.
Bye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.